Good afternoon, everyone. Hope everyone had a good lunch. Welcome to the deep dive on preventing pandemics. The deep dives are my absolute favorite sessions we have at Spotlight because we get a little more time to really dive in. It's my honor to introduce Bridget Arnold. She's head of communications for BGC3. For those who don't know what that is Bill Gates' private office. And in that office, they look at investing in and supporting all forms of innovation that make the world a better place. And I can't think of a better person to help Bill do that than Bridget. So Bridget, thanks for hosting this panel and for everything that you do.
Thank you, Katie. It's really an honor and pleasure to be here. I have never come to this event, and all I've heard for years and years is how fantastic it is. And even in 72 hours, that has borne out, and I've had an amazing time, and I'm really excited to welcome this group of panelists. It's an amazing collection of people who are coming at what could promise to be the most difficult thing we face as a humanity. And we have a group of experts here who are coming from a variety of places, whether it's the private sector, the public sector, philanthropy, and I think that's important because it's going to take everyone coming at it from many different angles to try to figure out how we prevent the next pandemic. Many people in global health and beyond have predicted that actually a pandemic would be more devastating to us as a civilization than nuclear war, bioterrorism, or any other scary thing we watch on TV or in the movies. And so not to start this off with fear-mongering, because we are all getting plenty of that, but I would like to, we're going to, as Katie said, this is a deep dive. So we're breaking it up into components, which I think will make it very engaging and allow each of our experts to go deep in certain areas. And then at the end, we'll bring them back up so that we can have questions from all of you, or as many of you as we can get to. And what we'll do is we're going to start with remarks from Dr. Fauci. Then we are going to move into a conversation with myself, Mark Henderson, and Luc Doubloon about SEPI, which is an interesting, exciting new coalition. After that, Dr. Ngozi Irandu at the end here will give us a brief talk that will be sort of her perspective on global health and this specific topic. And then finally, I'll talk to Mark Stilinski about some of the most exciting innovations he's seeing on the horizon in this area. So let's go ahead and invite Dr. Fauci to give us some remarks. Many of you know him. He's the director of the National Institute of Allergy and Infectious Diseases at the National Institute of Health, and chief of the Laboratory of Immunoregulation. He's one of the key advisors to the White House and Department of Health and Human Services on public health preparedness initiatives against emerging infectious disease threats. Dr. Fauci? Oh.
Wow.
This is a tough way to start.
So your audio visual guy
That's rough.
has shackled me
Can
to
we,
the stage.
I'm afraid to stand up, actually. I'm worried that it's gonna, what's going on here? Let's see. The same is happening to me.
Okay, you could go. It's your umbilical cord.
Wow. We're sort of like on leashes up here. This is really unnerving. All right.
It's like an astronaut.
I know, right? Okay. You're off leash now, Dr. Fauci.
Good. Okay. Thank you very much, Bridget. It really is a great pleasure to be here with you this afternoon to talk about this very important topic. I've been given the task in about 10 or 12 minutes to give you an introduction and an overview in this topic that we'll be discussing at a deep dive, namely preventing pandemics. But I want to start off by saying when you talk about preventing pandemics, you have to really talk about the fact that there is a triad of that, of prevent, detect, and respond. And if you really want to prevent an outbreak or an epidemic from becoming a pandemic, there's important issues there regarding detection and response. So we really shouldn't be separating them. So in order to get to that point, I'd like to just take a minute or two to do something that I think is important when you take this topic and go into a deep dive, and that is to essentially define what you're talking about. Now, when I look about infectious diseases, I look about it broadly into two big buckets: established infectious diseases and emerging and re-emerging infectious diseases. It's interesting because among the established infectious diseases, there are about 56 million deaths per year in the world, and about 16% of them are due to infectious diseases. Predominantly, when you think about the burden, it's obviously in the developing world. Now, among those, for example, there's 3+ million deaths due to lower respiratory infection. It's not that we don't pay attention to them, but we're not afraid of them because they're predictable. There's 1.1 million deaths due to diarrheal diseases, mostly among children. Again, we're not afraid of them. We should be responding more than we do because they don't have the potential of exploding. It's when you have a new emerging and re-emerging infectious disease that can either be an outbreak. We had an outbreak of measles in California because of the lack of vaccination. That wasn't an epidemic, it wasn't a pandemic. An epidemic is an outbreak of great concern, but somewhat restricted. We had an epidemic of Ebola in West Africa. It wasn't a pandemic because it didn't get into the developing world. We have a pandemic with influenza in 1918 and H1N1 in 2009. HIV/AIDS is the pandemic of our generation. So let's keep those definitions straight. Now, what about the history? Our entire society, from the beginning of our ability to make history of it, has been influenced by pandemics. From the 14th century bubonic plague to the 15th century syphilis and other sexually transmitted diseases, to yellow fever right here in the United States in the 18th century, to the 1918 pandemic influenza that killed 50 to 100 million people worldwide. So we are historically steeped in pandemics, even though because they occur so unpredictably, we may go a generation or two without it, and we kind of think it's something that's just history. But it's not, and I'll get to that in a second. Now, there are a number of factors that predispose us to emerging and re-emerging infections. Probably the most important is human behavior and demographics. For example, in Africa with HIV, the end of colonialism and the disruption of the family unit led to a sexually transmitted disease simultaneously with the sexual revolution among gay men in the United States, which would have been relatively benign had not a virus got inserted into that revolution. Economic development and land use, encroachment on the environment, yellow fever in Brazil, which is what we're seeing now, international travel and commerce, Zika, which marched its way across the Pacific to land in Brazil, West Nile, which somehow or other a person, a bird, or a mosquito got on a plane in Tel Aviv and landed at Kennedy Airport, and now we have West Nile in the United States. Breakdown of public health measures, Ebola in a particular part of the world that was beset with civil disorder, civil war, and lack of infrastructure. And I could go on and on. So there are things that predispose, so at least we know a bit about it. Importantly, among those predisposed things is that about 75% of all new infections are zoonotic. So are we going to have more pandemics? Well, I'm going to put it in real time and tell you a very brief 2-minute story. In the interval between the election of President Trump and his inauguration, Dennis McDonough, who was the chief of staff of President Obama, organized a meeting to bring the soon-to-be cabinet of the new administration into the White House in January before the inauguration to talk to them about possibility of emergencies that they may face in the first year, and historically what that was. And there were 4 of them. 1, a terror attack with bulletin bombs, 2, a cyber attack, 3, another Hurricane Sandy, and 4, the possibility of an unexpected outbreak. Now, we had everybody there who was involved in that. Myself and Tom Frieden and Secretary Burwell were involved in discussing what administrations might face. And I went through with them the 5 administrations that I've had the privilege of serving as the director of the National Institute of Allergy and Infectious Diseases. And if you go through each and every one of them were faced what would be either a pandemic or something related to an outbreak. Ronald Reagan, HIV/AIDS. George H.W. Bush, continue with HIV/AIDS. Then you wound up with Clinton, who then had West Nile virus. Now remember West Nile virus. That is an example of one of the predisposing factors. We would not have had West Nile virus were there not the ease of transportation. Literally a plane ride from Tel Aviv to Kennedy Airport. In 1999, we had 25 cases. In 2000, we had 60. In 2001, we had 42. And then bingo, 4,000 in 2002, 9,000 in 2003. Now it's endemic. And the word endemic is important because outbreaks, when they occur, after the initial outbreak, they may come into endemicity. We've seen that with several outbreaks. Then you wound up after that with George W. Bush. Now, George W. Bush had the beginning of the pre-pandemic H5N1, but he also had SARS. Now, remember SARS. SARS could have been a disastrous outbreak. It was one of those things that related to the issue of, again, travel. You might remember there was an infection in the Guangdong province of China. Somebody got on a plane, went to Hong Kong, stayed at a hotel, infected 19 people. They all got on planes, and then we had a true epidemic of SARS. Lucky for us, it burned itself out because of public health measures. So we escaped a bullet on that. And then you had the situation where I probably spent more time in the Situation Room over the last 8 years with President Obama, because he came in and no sooner did he walk into the Oval Office that we had the first pandemic influenza of the 21st century, the H1N1, followed by a few other things, MERS, chikungunya, and then Ebola, and now Zika, with which we're still living through. So the bottom line lesson is that pandemics happen. They have happened before we were here, they're happening now, and they will continue to happen. So what have we learned? I had to summarize it in a couple of minutes. Like, what were the lessons learned of literally 5 administrations of dealing with varying degrees of severity of outbreaks? The first, we need better surveillance, and we have a global health security network that we've started that hopefully will get us to see things that happen before they become a pandemic. Remember, a pandemic is an outbreak before it becomes an epidemic, before it becomes a pandemic. And I think that's what we're going to deep dive in. How do you prevent that transition? For example, the surveillance of a child recognizing that a child in Guinea got infected in December of 2013, and we didn't know that we were having an Ebola outbreak until March and April of 2014. Surveillance in the southwest part of the country with the swine flu of 2009. We could have done much better to prepare. The other thing is transparency and communication. The Chinese knew back in 2003 that this respiratory infection was not influenza. However, they didn't communicate it. They've done much better since then, but had we known we were dealing with a brand new coronavirus infection, we may have been better prepared. Infrastructure and capacity building. When we went into Liberia, what we did is we created an infrastructure so that they will be able to respond to the next epidemic. The infrastructure that is associated with PEPFAR is now preventing countries from actually getting a pandemic. In addition, there needs to be coordination and collaboration, and there needs to be the development of platform technology. It is very difficult to be chasing after possible pandemics as opposed to having in place the technology like vaccine platforms that can be easily adaptable. Okay, finally, what is next? We don't know. They asked me. Somebody raised their hand. I won't tell you who it was. So what is the next one that we're going to have? That's the whole point. You can't predict it. Is it yellow fever in Brazil that's now going to get into the Aedes aegypti mosquitoes and work its way up to other areas in the south, namely the Caribbean and Puerto Rico? We don't know. Are we going to have a Zika return? Is the H7N9 pre-pandemic going to turn into an explosion? It's a big unknown. But the one thing that we can be sure of, that we will continue to have emerging and re-emerging infections. It's our job to prevent them from becoming pandemics, and hopefully we'll be able to deep dive into that over the next period of time. Thanks.
Thanks, Dr. Fauci. Thank you. So one question based on those remarks that I think is interesting, and in the sort of the history lesson you just gave us, which is fascinating, and working with all those different administrations over the years. Was there an insight that you observed or were participating with that was very effective in one of those administrations? One, either a key piece of insight or a key sort of approach to the situation that you felt meant they were more successful than another?
Well, you know, I certainly wouldn't want to, if I could, compare one to the other.
Right.
But I can tell you some of the things that actually worked. So I just take the most recent, which is in everyone's memory, namely the two things that we've experienced, namely Ebola and Zika. It was the direct involvement and collaboration of all the agencies involved and having a situation where literally twice, 3 times a week, I was on the phone with Tom Frieden every night. We had conference calls with Secretary Burwell, with the FDA, with the CDC, and we met with the president, I would say, so countless times, I can't even tell you how many times during Ebola. The same thing with Zika. So when you have commitment and involvement from the very, very top, it's amazing how that gets translated into cooperation, coordination, no nonsense, do your job, because the people who are at top are really looking at it. And I think that's really important.
Interesting. Yeah. Okay, great. Well, thank you, Dr. Fauci. So now let's turn to Mark Henderson and Luc Doubloon. We're going to have a conversation with the two of them. Both come, again, from very interesting perspectives. Mark from the philanthropic sector and Luc from the private sector. Mark's the Director of Communications for the Wellcome Trust, which is the world's second highest spending charitable foundation, which works to improve health through science, innovation, and engagement with society. He was also part of the team that led the Wellcome's contribution to SEPI, which is a new global alliance that will hopefully stimulate the development of vaccines against epidemic threats, which is going to be largely what we'll talk about. And Luc is the president of global vaccines at GSK. You've been with GSK more than 25 years, working as a commercial strategy director and R&D before leading the European Commercial Center of Excellence in 2005. Luc's also a member of the International Federation of Pharmaceutical Manufacturers and Associations, Vaccine CEO Roundtable, and a member of the Management Committee of the Belgian Federation of Enterprises. Thank you both for being here. So I think one of the things about this topic today that is pretty clear, we may not all agree on how we get to the solution, but I think there's a pretty unanimous sense that what we've been doing in the past, the status quo, isn't going to be enough. And so SEPI, the Coalition for Epidemic Preparedness Innovations, is, I think, a great example of a new way of thinking, a creative partnership, one with flexibility to address both the unknown as well as the known. Can you tell us a little bit about SEPI, Mark, and what the objective is?
Sure. So SEPI is a collaboration that we launched in January this year. It's led by Wellcome, the Gates Foundation, governments of Norway, India, Germany, and Japan are the core founding partners at the moment. And it's essentially a structure to fill those gaps in vaccine development against epidemics, where we know that we could be developing vaccines against some of these threats in 2 different categories, but we're not doing it by and large because the market incentives are not by and large there. So what SEPI will do is it will approach 2 different kinds of epidemic threats. First of all, if I'm going to channel Donald Rumsfeld for a moment, we've got the known knowns. These are your kind of diseases that are out there, as Ebola was in the past, that we know could come and bite us at almost any moment. So there's a list of 11 or 12 of these diseases that are kind of categorized as great threats by the World Health Organization. And SEPI is taking on 3 of these. So MERS, which Dr. Fauci mentioned. This is the Middle East respiratory syndrome, circulating principally in the Arabian Peninsula. There's Lassa, hemorrhagic fever, mostly in Africa, and there's Nipah, which is another disease, viral disease, mostly in South Asia. And in each of these cases, what SEPI will do is it will work with the pharmaceutical industry and the biotech industry and academia to take candidate vaccines through all the stages of development that you can take them through before there's actually an epidemic. So we take these diseases, we take these vaccines through the safety tests, through the proof that they stimulate an immune response. What you can't, of course, do is do those final tests, the final tests of whether they're actually effective in the real world until there's actually an epidemic. But the critical thing about what SEPI's work will do is it will mean that when that happens, we won't lose any time. This contrasts enormously with what happened in Ebola, where actually in Ebola, the world did a good job, by and large, in the end, but it took a while. We first had to win the argument that there should even be any research. And of course, epidemics are a tragedy, but they're also an opportunity to learn and to sort of tool ourselves up for the next time around. And we haven't taken that opportunity historically. So we pulled together a incredible collaboration, drug companies, including Luke's, philanthropic organizations such as my own, governments, etc. And we were able to move faster than we've ever moved before to test vaccines in the teeth of an epidemic. But even that was too slow. Even though we won the argument that we should be doing research at sort of August, September 2014, the first vaccines didn't go into any arms in West Africa until the spring. And the reason for that is we were behind the curve. When we won that argument, we had to do the safety testing. We had to do all kinds of things that could have been happening when there was no epidemic around. So that's the first thing SEPI do will be to fill that gap. The second thing is, again, as Dr. Fauci mentioned, you've also got the known unknowns, the diseases we know nothing about just yet. We know that they're there, but we don't know what they are yet. So we can't build a vaccine against them right now, but what we can do is build adaptable vaccine platforms that you ideally will be able to be in a sort of plug and play model. So we know that this vaccine platform will work, and then you plug in the DNA, the RNA from the disease that's actually threatening you, and you're able to dramatically shorten the vaccine pipeline.
That's great. So, and it's an interesting partnership, right? Creative, maybe unusual bedfellows to a certain extent. But can you tell us, Luke, from your vantage point, give us a little bit of the color about everything coming together and your perspective as a key leader in this effort, why you got involved and how that has been since January.
Well, thanks first for being here amongst this very special panel. Let's first say that we are very pleased actually with an initiative like SEPI. But let me give a bit of a perspective from the industry. So GSK, for those who don't know GSK, we are actually one of the largest manufacturers of vaccines, and we develop those vaccines. And it's important to understand that perspective. We produce 2 million doses per day. So we shipped last year 833 million doses to more than 170 countries. We have 40 vaccines that are used currently, both in pediatric settings, adolescent settings. And I'm saying this because we are also researching 15 new vaccines. I can talk about that, but that's not why I'm painting this picture. The fact is that when Ebola happened, we get a phone call. We're the first to get a phone call of, do you have a vaccine? And actually with Ebola, we were kind of, I would call it lucky, because we had just bought a company in Italy, Okairos, who had actually the Ebola first vaccine on the shelf with a platform, adeno platform, a technology platform. And we were able, as Dr. Fauci said, by collaborating massively with all involved parties, regulators, WHO, NGOs, Bill and Melinda Gates Foundation, to put our heads together and work on that. But you can imagine what a disruption that is to a company that is actually, today we know that because of the demographics, more and more vaccines are in demand. The value of vaccination has been proven. It's close to clean drinking water, the intervention. And therefore, actually, any production that we do on Ebola interferes with the normal production of a vaccine. And therefore, the message is we cannot continue to live like that. We don't have factories waiting until Ebola happens. And therefore, we need to be better prepared. And that's why I applaud an initiative like SEPI. And GSK has a specific, but I'll maybe talk about that later, biopreparedness organization proposal to permanently work on that.
Yeah. Well, tell us just a little bit more and how that works sort of as a complement to SEPI.
Well, it should be in collaboration with SEPI. So the idea is that we have a permanent, dedicated organization working and validating platforms. Again, referring to Dr. Fauci, we don't know what it will be, and you said it as well. We don't know what the next virus will be or bacteria will be, and therefore we should be constantly developing platforms where we then can plug in different viruses when the pandemic presents itself, and then we can accelerate the manufacturing of that. Permanent dedicated organization that has access to all the technologies that we develop in our commercial vaccines. And you mentioned there is no incentive for the market. Actually, we want to do that at no profit, no loss. So it's not to make money, it's to give the world access to our knowledge in a focused way, rather than constantly interfering with the normal way, because we can't be ready. We now developed the Ebola vaccine. Normally it takes 10 years to develop a vaccine, and we scrambled our best scientists. But guess what? We had to delay development programs for other very needed vaccines. So that's why we think it's good to have a SEPI organization. My hope is that we can start really working on it and deliver and create the confidence in the world that this kind of insurance way of working really can pay off.
One of the things that really struck me, I think, listening to some of the discussions as SEPI was set up, was actually listening to people in the pharmaceutical industry who really did take on a hell of a lot of risk in Ebola. Opportunity cost, as you're talking about, but also risk. I mean, doing vaccine trials is not straightforward. There are liability risks. There are all sorts of things that can go wrong. Not because vaccines are inherently unsafe, but because that's the nature of the game when you're testing anything new. And it was incredible the extent to which the three companies so GSK and Johnson & Johnson and Merck really did take this on and ran a huge amount of risk in order to work on the three different Ebola vaccines. But of course, this worked well for Ebola, but it worked once, and it's not sustainable. And we can't rely fundamentally on the goodwill of industry again and again during these situations, not because you don't have the goodwill, of course you do, but it's just not reasonable for us to expect you to do that again and again and again.
No, we will obviously always take our responsibility, but the word permanent and sustainability is very important. Just to give you an idea, Ebola, when it happened, the whole world is on it. It's on every magazine, and all organizations go there. The funding goes pretty smooth, actually. Research institutions jump on it. And then when the WHO declared certain countries Ebola-free, that drops away. But guess what? We were still doing our research. We were still finishing trials. And it's a situation that is actually not sustainable because you need a sustainable industry and we need sustainable research. And it's a collaborative effort because it's not just the industry. Regulatory science is something that needs to be developed as well. How do you go about approvals? Do you go the classic way of a normal vaccine, which can take many clinical trials and all of that? Is there a way we can accelerate that? We did for Ebola, but can we repeat that? Can we learn from that? So there's a lot to be done there as well.
And of course, critically, this has all got to be worked out ahead of time. Because again, during the Ebola epidemic, we had all sorts of well-intentioned and important arguments about actually what was the right way to test these vaccines in the epidemic. And we lost time because of that. There's no reason why those conversations can't be happening now when there's no epidemic, and indeed they are now, and that's one of the big benefits. How are you going to get the vaccine licensed at the end of the day? What will the FDA require? These are really important questions that you need to be able to settle ahead of time. And I think those are some of the things that the global community is starting to take on. I guess the other thing with SEPI is it's formed, it's up and running, it's taken its first proposals for these three diseases, Lassa and MERS and Nipah, and some of the best of those will be going to the Scientific Advisory Committee and on to the board to make final decisions about funding in the autumn, fall. But of course, we're only partway there with supplying it with the necessary funds. So in order to fulfill its mission, SEPI really needs $1 billion over the first.
Where are you now? You had $500,000 at launch in January.
We're a little bit up from that.
Okay.
We've had a few.
Europe had added for 700 now.
Yes, the European money has some strings attached. And Australia has put some money in, Belgium has put some money in, there are some other contributors, but we do need more donors. So if I can ask all of you to do anything, put pressure on your governments, particularly to put money in, because this is a really important initiative. It's not the only initiative. Just something that's important to say here is it's critical and necessary that we develop vaccines against the threats we know about and platforms that can deal with the threats we don't know about, but it's not sufficient. We need to be investing in surveillance, in community health workers, in all of the kind of systems that help to make the body politic
because
stronger.
even if we have a vaccine available, then the countries need to have this healthcare systems and the healthcare workers in place to do that. And actually, to completely prevent it so that you don't need a vaccine is maybe put the fundamentals of healthcare systems, which we discussed this morning at the breakfast.
Because Ebola, when you look back on it, was not ended because you were able to deploy and distribute a vaccine.
No,
right?
correct.
In
we
this
didn't
most
use it
recent
actually.
instance. So
However,
all the pieces come together.
it can significantly reduce the potential for growth of an epidemic. And what we need to be in a position is with pre-agreed protocols and deployment plans for everywhere that's at risk. So recently you'll be aware possibly there's been an outbreak of Ebola in the Democratic Republic of Congo, which fortunately has come under control using the kind of classical public health interventions. So that's really to be welcomed. But the vaccine was there and could have been deployed, and indeed DRC did some great work to ensure that the licensing and approval was completed very quickly. But even then, actually, we could have been moving faster than we did. The WHO now recommends that this vaccine that we have available for Ebola, even though it's not fully through the licensing process, should be deployed in a ring or is available to be deployed in a ring around cases where necessary. And what we really need is probably for every country that knows it's at risk of Ebola to have worked out how they would do that now.
Interesting.
Just a quick it's a pretty much of a maxim that if you start de novo from scratch in developing a vaccine in a new outbreak that was completely unpredictable, you will always be behind the curve. Always. And that's the reason why we talk about platform technologies that are easily adaptable to start. I mean, a typical example of an embarrassment was the vaccine response to the H1N1 2009 pandemic flu. It was in April that it was first recognized, at the end of the flu season. We knew for sure that in the fall, when the kids came back to school, we were going to have a big outbreak. So we started to make a vaccine in the typical antiquated, grow it in eggs way over the summer. And if you look at the curve, it goes cases, peak, vaccine available.
Right.
And it was not good.
Right.
So that's just such a classic example. If we had platform technology that we could have cut off 3 or 4 or 5 months from the process, we would have had a vaccine in time for the children who went back to school in September of 2009.
And there was another missed opportunity in the 2009 pandemic as well, because this isn't all about vaccines. The research response, we also need drugs, we need diagnostics, we need all these kind of things as well. Now, many of you are probably aware there's a great controversy over whether the frontline drug, antiviral drug against flu, oseltamivir or Tamiflu, is effective or not. We had a golden opportunity to find out whether that was true in 2009-10, and we flunked it. We didn't really do that research. And where we ought to be is in a position where research is sort of baked into the epidemic response. Obviously, saving lives and helping people has to come first. But if we start from the premise that these are opportunities to test things as well, to get ourselves better prepared for next time around, we will save many, many, many more lives in the long term and save money.
So you mentioned the 3 areas that SEPI's initially focusing on, but are there other areas in terms of the research and development that you think we're really behind in?
Well, I mean, as Dr. Fauci said, I mean, the technology platform, that's where we should invest, absolutely. So this should not be virus specific, but just making sure that we validate them constantly with different viruses, so that when then an unknown virus is out there, we can actually just plug it in and plug and play. So if I give an example of what we actually are doing on Zika together with the NIH, with the SAM technology, and please correct me if I'm wrong, I'm not the scientist here, but in lay language, it's basically injecting the code so that your body starts to produce the vaccine against the virus that is entering your body. That's the technology of SAM technology. That is almost like a 3D printer of the code, the plasmid. And if you think about that, then in the future, when anything happens, we can easily scan the code, develop the vaccine, and make your body produce against it. That's the future. Am I correct?
We should never, ever have to grow a virus, inactivate it, or attenuate it for a vaccine. We could sequence it in hours, and we could stick it into one of the platforms and get it, I mean, literally shave months and months and months off. So that's really the future of vaccinology. I think we have to just shed the old, time-honored, but nonetheless not particularly adequate approaches over the years.
Who's doing interesting work in this space right now, in the platform technology arena?
Well, I think the truth is that there are only a handful of vaccines companies, and we are all investing actually into that technology. For GSK, we scan the world constantly, so we have the adjuvant technology that is developed already 20 years ago, but which was very instrumental during the flu pandemic in 2009, because it enhances actually the immune system, how it reacts, and therefore you need less antigen when you combine it with the adjuvant. So you have more doses, you can help more people in the world. Right. For Ebola, we've used the Chimpadino platform, which we bought Okairos, and then the SAM technology. We acquired Novartis vaccines 2 years ago. So we have many. But to make it very clear, because I'm sure people think, the industry, here, this is not about competition. This is about competition against that virus and making sure. So in the Ebola space or in the SEPI space, we need to collaborate.
Right.
Not that we need to give each other's technologies, but we can use each other's knowledge with the right patterns around it, which are the nature of our core business,
And
of course.
one of the great things about SEPI as it's developed is all 6 of the major big pharma companies that make vaccines are on board and are contributing and are part of that. And that was not a given at all. And the other point is that SEPI is concentrating very specifically on those vaccines, those diseases where we don't think that market incentives will drive in the necessary innovation and research and development on their own. So actually influenza, while obviously the most important disease that we need to defend against, and we need better vaccines, we need a universal vaccine ideally. Obviously, if your company, Luke, were to develop a universal vaccine against flu, there'd be some money in it. The same is not true of Lassa or MERS or Nipah or many other diseases in the same way. They're too sporadic. They tend to affect countries where people are poor and there isn't the market. There are a whole host of reasons why we probably can't expect the market to drive that on its own.
But the models are there. I mean, if you think about malaria, which we've developed with the Gates Foundation, with PATH, I mean, it is possible to develop vaccines. We are a business. We need to be a sustainable business. We're not a charity, but in a good collaborative effort, we can tackle these epidemics working together. We can work for diseases of the developing world, like malaria vaccines. So it is quite possible if each one brings his piece to the table.
So that's it. We've got the public sector. We've got governments involved in this intimately. We've got the philanthropic sector, Wellcome, and the Gates Foundation, and the private sector. And no one of those sectors could really do this on their own.
Correct.
And that's why, if this continues to go as well as it has been, it could become quite an exciting new model for taking on some of the other challenges in epidemics and who knows, potentially in other global health threats as well.
Great.
So in a nutshell, it's asking governments to pay an insurance policy.
It is an insurance policy.
It's an insurance policy. And SEPI is not a company, but SEPI can facilitate sustainable funding. The regulatory mechanisms work on that together. And thirdly, I think it's important that they are a convening power, bringing those parties together, and then determine the science. We should not, as a company, define the scientific priorities. That should be WHO and the scientific committee. And I think that's the role really that we expect from SEPI.
And of course, just a final point, if I may, it won't do it on its own. It's one piece of the puzzle. SEPI and the availability of vaccines, for a start, it'll only protect us against some diseases. And secondly, there are a whole host of other measures that are necessary that I expect you'll hear more about in the rest of the panel.
Great. Thank you both.
Thank
Very
you.
interesting. Now we're going to turn to the other end of the room here, and we're going to hear from Dr. Ngozi Arandu, who I had the pleasure of spending much of my day yesterday with. She's going to talk to us. She's an assistant professor at the London School of Hygiene and Tropical Medicine and co-founder of the Global Bridge Group, a global health consultancy. She's an infectious disease epidemiologist and global health policy expert. Her work combating polio in Kenya in 2011 inspired her to become an operational researcher. And one of the things I will note too is despite these amazing credentials and a very scientific bent, she is a very powerful advocate and voice for the people behind the numbers of many of these issues that we're talking about today. So welcome up.
Thank you. So I want you all to imagine this scene with me, okay? There's a mother, and she's staring at me. She's looking at me intensely and a bit anxiously. And all I'm doing is describing the symptoms of measles, so I'm not really sure what's happening. So as soon as we finish, she runs and she gets her 2 little boys, and they just look miserable. Their bodies are covered with spots, and they've been scratching themselves so hard that their skin has begun to tear. And the colleague that I'm with, he's a World Health Organization doctor, he scrunches up his face and he looks at them and he says, "That's not measles, that's chickenpox." And with that, he just turns and he walks away. So the mother, she is understandably puzzled, and then she's increasingly becoming upset. And I just feel so bad because there's really nothing that I can do, because even though my colleague was tactless, he was right. We were there on a global mission to eliminate measles. We were talking to community members and villagers, telling them about measles and encouraging them to get vaccinated in the immunization campaign. So that's all we were equipped to do. And see, that's what global health initiatives are like. For the past 20 years, we've been investing resources and expertise on specific diseases, and then we go out for those specific diseases. So I didn't have chamomile lotion, not to speak of antivirals for chickenpox. And chickenpox might sound benign, but if you're from a low-income country, then you're 20 to 50% more likely to die from that. So today I come to you as a card-carrying member of the global health community. And we have done some great things. My panel members have talked about a lot of the things that we're doing now. We've eradicated smallpox. We're on our way to doing the same with polio. We're trying to eliminate measles, guinea worm, and a lot of other diseases. But as I enter my 10th year as a field epidemiologist who has worked in several large international health organizations, I have to tell you that we will never be able to stop preventable pandemics in poor countries, because we will always be too late. The only way for us to stop preventable pandemics or outbreaks in poor countries is if all communities where those outbreaks originate, if they have professionals, products, and processes in place that comprise an effective and a functional health system. That's the only way we'll be able to do that. So let's go back to the field. Now I'm in Chad, and I'm looking for meningitis cases. And I want to talk to the health workers. I'm saying, how do you confirm a diagnosis of a suspected case of meningitis? So they tell me meningitis is a bacteria that infects the brain and the spinal cord, and so you have to remove some fluid to be able to send to the laboratory for a diagnosis. And so you do a lumbar puncture where you put a syringe here and you pull out that cerebral spinal fluid. And so they said during outbreaks, they usually have to reuse these syringes because they don't have enough. They have to reuse syringes. So then they put the spinal fluid in like a specimen container. Let's just think of it like this. And because they don't have any other packaging or materials for biohazards, they put it in just an ordinary envelope like this. Then they walk over to the bus depot, and they find someone that's going the same direction of the laboratory. They give them a little bit of money, and they hand this over to them. That person sits in a bus full of babies and mothers and animals and whatever else with a potentially deadly pathogen. Can you imagine if you were just sitting next to someone right now that was holding something that if it infected you, it would not only kill you, but your loved ones as well? Andrew, could you hold this? Thank you. But what if in Chad they had professionals, like well-trained doctors and nurses that were able to perform lumbar punctures in a sterile environment? And what if they had enough products, like syringes or materials for biohazards? And what if they had good processes, like a secure laboratory specimen network, that we were able to ship a sample from the health facility all the way to the laboratory, and you're able to track it as well? Well, if Chad had that, then Chad would be just like the United States of America, a country that's able to protect the health of its citizens, but also contributes to the global health security. But we weren't always like this, right? Like Dr. Fauci said, almost 100 years ago, the Spanish flu killed over 50 million people. Back then, we didn't have antivirals. We did not have we didn't have a flu vaccine. We didn't have an effective system to track the disease and contain it. But all that changed with enormous investments in our national health system. Now we have exceptional institutions like the Centers for Disease Control and Prevention. We have the National Institute of Health. And these institutions have the best experts, cutting-edge technology for laboratories, and in collaboration with the local and state health departments, they're doing their best to continuously protect the health of American people, and really to protect the health of the world. So that really gives me hope. And what else that gives me hope is that there are some smaller investments in low-income countries. For example, there's the University of Global Health Equity. Some of you may have heard of it because we have some of the founders here. It is a university that was created 3 years ago by the Ministry of Health in Rwanda and Partners in Health, which is the NGO that was founded by Paul Farmer and Jim Kim. And the goal of this university is to create global health leaders from low-income countries, giving them state-of-the-art education, and also just committing to providing equitable and quality health care for anybody who needs it. So that gives me hope. SEPI gives me hope, an initiative that, like my colleagues have said, that looks at diseases that may not make money for these pharmaceutical companies, but things like this gives me hope. And these are bright lights in sometimes a very, very dark situation of when you think of pandemics and you think of outbreaks. But we still have so much to do. Because in the US, there is one doctor for every 400 people. In Guinea, there's one doctor to every 10,000 people. So which country do you think would be able to detect an outbreak of flu early enough to save countless lives? Okay, so today I've talked to you about measles and meningitis, even the Spanish flu. And the reason why I gave you these examples is to say it's important to invest in national health systems in poor countries. And they deserve investment just like we did. And if they are invested in appropriately, these health systems, these professionals and these products and these processes, then in the next 10 years, we will be seeing a very different picture, and we'll be able to more confidently reduce the threat of pandemics all around the world. So today, I have an ask as well. I'm asking you to talk to your organizations, talk to your congresswomen and men, and ask them to strategically invest in the professionals, the products, and the processes of poor countries. Then one day, another mother can take her 2 children to the health facility right around the corner, where she'll be greeted by a very well-trained nurse who will look at them and say, "That's not measles, that's chickenpox. That's okay, I can treat you." Thank you.
Thank you, Dr. Arandu. You spoke a little bit about places where you've seen it working and you've seen progress and improvement in your time in the field. Can you tell us a little bit more about what you think the ingredients of that improvement are?
Yes, definitely. So one thing that we've been talking about throughout Aspen, as well as in the incubator that I was with you in yesterday, is the last mile, right? Like having trained people on the ground. And while today I talked about professionals like doctors and nurses, community health workers are very important as well. And in these countries, sometimes there's no road to get to these villages and these communities, and the people there, they're the first line of defense against any type of outbreak or disease, and they're also the first line of communication to the health facility or the health center closest to them. So having trained community health workers in place, that's a very important component to this.
Great, thank you so much. Yeah. So now we're gonna have a conversation with Mark Stilinski. Hi, Mark. Hi. I also spent a lot of time with you yesterday. Mark is the Chief Medical Officer and Director of Global Health Threats at the Skoll Global Health Threats Fund. And in his role, Mark's led global efforts toward early detection and rapid response to emerging threats. His work has brought together governments, NGOs, academia, and private industry in partnerships across national borders in Southern Africa, the Middle East, Asia, Russia, and Southeast Asia. So, Mark, tell us a little bit about how you came into this work, because it wasn't a straight line for you to this stage.
No, for me, you know, everybody has sort of that pivotal moment. I went to the medical school at the University of Michigan, and I always wanted to go into public health. And I remember even in my yearbook, people wrote, "What the heck is this?" You know, and going to a big research school at Michigan, it wasn't a popular decision, but I ended up going to the University of Arizona, and while I was a resident in preventive medicine, the hantavirus outbreak occurred in the southwestern corner of the United States. And so to be a young resident, and there was only one doctor at the health department in the state of Arizona, and to see a newly emerging disease that nobody knew anything about. We obviously had no control measures like vaccines or drugs for this at the time, and to also experience the discrimination from a disease that occurred because it was on the Navajo reservation, and to witness something that clearly we saw with the HIV and, you know, the initial cases being among gay men, and certainly having lived through that as a resident in medicine, it was fascinating to see here was another disease that had a discriminatory component to it, which is not unlike what we see in a lot of diseases around the world. So that's when I was like, the rest of my life has got to be about focusing on finding these new outbreaks and really trying to tackle that effort.
Got it. Well, and you have created, in your capacity at Skoll, you've created the endingpandemics.org website.
Yes.
Which is a very cool resource. And for any of you that are interested in anything that's come up so far, I encourage you to look at it. Tell us a little bit about how that came together.
Yeah, so that was the number one request that we had from our grantees around the world was every time we would do something in a country, and our process is really trying to take technology that already exists and move it into the public health community around the world. And what we do is to use local developers to take technology that they've seen, but build it for their countries with their governments. And as we've done that, everything is open source, so a neighboring country can look at it and do that. So the number one request was, how do we find all the things that you've done in the different countries? And so after we heard it, you know, so many times we made a commitment and said, all right, let's build a website and put everything we've ever done in there. So if you go to this, you can click by country, and you can see all the projects done. If any products were developed, you can go into the resource, you can actually get the code. And so it's been an idea that could we create a community of practice so every investment we've made across the globe could help nurture others and make it freely available.
One of the things that struck me about some of the stories you were sharing yesterday, specifically related to technology as a key intervention in this issue, has been that, you know, often there's criticism leveled at technology in terms of being viewed as a panacea or a silver bullet. You seem to have struck a good balance between recognizing the value of technology in certain situations, but also how to work with local communities at a country level to create solutions that are more effective. Can you tell us a little bit about that?
Yeah, sure. So for us, it's not the technology, it's the person who's using the technology. So we feel like we're investing in people. But at the same time, we need to give people who are in these countries the ability to use technology that they may just have never been exposed to. So our approach, and I apologize for those who might have been on the other panel, in order to do that, you know, the days of everybody coming in and sort of bringing a software program to a Minister of Health and say this will solve all your issues, those days are over. Because what happens is 2 years down the road, either that organization doesn't exist anymore, there was no funding, and then the ministry's left holding a tool that no longer has a back-end support or so forth. So today, what we've found out is there are great developers across the world in every country. And if not in that given country, certainly within their neighboring countries. So we decided to create a process that now we've done on 5 continents, and it was the first thing we've ever trademarked as a foundation, but it's an EPI hack. And what this is we'd bring epidemiologists and developers together for a week. And the idea was, and I learned this at Google, I was fortunate enough as a public health doctor to spend 4 years at google.org, where we worked with a team of engineers to build Google Flu Trends, which was the idea, could you look at search data and see if you could find early signals of flu. So that idea of having developers, and what those engineers taught me was, do not tell us how to solve your problem. Just tell us what your problem is. So on the first day, and everything we do is about One Health. I mean, you heard Dr. Fauci talk about zoonotic diseases. Everywhere we work, it's connecting the human and the animal community. Otherwise, we're not going to get ahead of finding those outbreaks. We can find some of these outbreaks faster in animals. So the epidemiologists in the human and animal sector tell these developers, and we do a 3-to-1 ratio, exactly what their problem is. And then they take the developers in the field and they go to the clinics, they meet the people, they see what kind of technology, and then they lock themselves away for the rest of the week and they hack in a hackathon. And then they develop a prototype at the end, and then we fund the most promising technology because it's owned by the government, it's done by local developers, it's all open source, and it's something they can continue to adapt and evolve as time goes on.
Do you do this in a grant-making capacity? Is this part of how your funding mechanism? Is it a percentage of the overall portfolio?
Yeah, so we're sort of a different kind of foundation. I mean, we don't meet like the classic definition of an operational foundation, but that's sort of how we consider ourselves, because unlike most foundations, we don't take requests for proposals. We're trying to solve the issue of finding outbreaks faster in every single country. So we go to the country, meet with the governments and say, we're here to help you. And so obviously we try to find the organizations in the ground who will help partner with the governments and sustain that. Sometimes we've made grants to organizations in those countries. Other times we've done it in a contractual, we'll find the tech company who can get it done. So we're not limited in saying it has to be done with grants. We've had the benefit of working for Jeff Skoll, who really started the Skoll Global Threats Fund, on the idea that we should be able to do whatever it takes, and we shouldn't be limited by traditional sort of foundations and the way they've done that. So it's been a great experience. But yes, I mean, we do give a lot of grants in the end to keep the projects going for a period of time. But the other thing we do is we bring all the partners from that country into the process. So we bring the private sector, the academic sector, and others who are there so that the government, who isn't really comfortable in the public health field for going out, like the SEPI project, we can do many sort of consortiums like it in the countries, and that's how we can sustain it going forward. Because it does cost money. I mean, nothing's free. Right. It's a very inexpensive way, some of the things we're doing in the technology, but ultimately, there's still costs involved with everything, and if that can't be borne by the government, it's awesome if we can help the industry who might be a multinational who understands the threat of epidemics and get them to partner locally.
Got it. So what are you most excited about now in your portfolio that you're working on?
I'm excited about a lot of things. One of the things, as horrible as Ebola was, there was good things that came out of it. And one of the things that came out of it for us, when Jeff Skoll started the Skoll Global Threats Fund in 2009 to tackle pandemics, water, nuclear nonproliferation, the Middle East conflict, and climate change, we were the only foundation out there who was saying we want to end pandemics. Fast forward to 2014, Jeff Skoll convened the leadership of Silicon Valley and said, it's more than money. We should all be helping. And at that time, we realized, wow, there's a lot of new foundations here who are interested in this. So we created a collective which is now 14 foundations, all focused on stopping epidemics or preventing pandemics. And we do monthly phone calls, and we meet twice a year in person, and we've done that now for the last 2 years, to really try to coordinate. So if, Gates Foundation is really invested in vaccines or drug development, that's awesome. But how do we do the work you're doing and combine it with our work that's focused on surveillance? And then how do we combine that with other foundations that are really interested in emergency operations centers? So we've mapped out sort of an entire spectrum of what it's going to take from prediction to prevention to response, and to have all of those foundations talking and thinking about how do we add value to each other. That's new and exciting. And not only to have those other colleagues who also care about the same issues we do, to really be talking together and thinking it is a systemic approach and we can't be in our silos even as foundations. So that's exciting. I think the other exciting thing is the drive in developing countries to really solve their own problems and to really want to use technology and to engage in the community. I think for us, what's most rewarding is that the general public is probably our best answer to finding and reporting outbreaks faster, and they're also the exact same people we need to immediately respond to whatever control measures are available. So, we call it participatory surveillance, but in each of these countries where, we don't want to have verticalized programs, and so what we're trying to do is work with countries where it's about finding outbreaks faster, and so even in the lack of diagnostics, even in the lack of vaccines, the idea that in real time now we can at least see symptoms being reported in animals or humans in a map in real time, that for once we can say, hey, there's some acute event going on there. And even with limited resources, you can take what you have and try to find out what's going on. Before, those things were all hidden sort of in the background of all the data because it wasn't coming in real time. So I think really trusting in the citizens in each of these countries and the community members to be part of the solution is really exciting.
Yeah. It almost takes the notion of the last mile. It actually is the first mile in many regards. Interesting. Thank you very much. Yeah. So now we have a chance to open it up to the room, and hopefully you've all had some thoughts about the various comments from the panelists, and we'd love to take questions. If there's anyone who wants to start. Yes? If you could tell us your name and your organization.
Sure. Anita Goel, Nanobiosym, in Boston, Massachusetts. Thank you very much for the wonderful panel. What is the vision of the panel for a future where we can do real-time global health surveillance, and how far are we off from this? And I want to describe the vision as follows, where you can combine all the big data capabilities with real-time diagnostic information, plus this 3D printing of personalized vaccines, and have a real-time feedback loop where they get rapidly deployed back in the field and you stream the data back in. How far are we from that vision, and where are we in that vision?
Who wants it?
Well, we're far. It would be nice to say we're almost there, but we're not, because it has to do with kind of a really advanced version of the global health security network, where you have capabilities of surveillance, point-of-care diagnostics, internet-type communication, so that you can not only recognize but essentially respond with all of the technologies that are available. That is going to require a major effort, not only for rich countries, but for countries that are essentially vulnerable but not necessarily having all the resources they need, to be able to devote a modest amount at least to their own global health surveillance and response. It has to be that way. An example that I alluded to very quickly during my brief introduction is that during the Ebola outbreak, when we went into Liberia and the CDC was in Sierra Leone and the French were in Guinea, we did something, I think, unique in the positive way, is that we built some infrastructure. We trained people. We physically built infrastructure, and we brought in computers to be able to communicate so that the next time you get a case of Ebola, they're going to respond 10 times more quickly. But that's something that we had to put the concerted effort into it. There's so many areas of the world that don't have the resources to do that. That's the reason why I think it's an aspirational goal, but it's going to take a lot more commitment and a lot more resources to get to where you want to be.
I must say, I like the goal because you paint clearly that it's end-to-end. Every single person who sits here, we all have to contribute to that solution. And my observation is that today we're still too fragmented. Everybody is doing with good intentions their own bit, but actually if you connect them, they will give potential to do way more. So it's a great ambition to have.
Great. Yes. Oh, I'm sorry. Behind you, he has the mic. We'll take you next.
Hi, I'm Gulrez from the RAND Corporation and an Aspen New Voices Fellow. I have this question about the emerging infectious diseases which are likely to come from permafrost melt. And I mean, in summary, we have been here for 200,000 years. Bacteria have been here on this planet for millions of years. Antibiotics and vaccines have been relatively recent, past century perhaps. So what we're talking about with permafrost melt, bacteria and viruses coming back into the environment which have been there frozen for centuries, how prepared are we in terms of developing responses, surveillance, vaccines, and treatments to this potential threat? Thank you.
You know, there was a big stir when several investigators, one of which was funded by my institute, went out and went to the permafrost and brought out the 1918 influenza, and there was some concern about sequencing that, about essentially bringing back a live virus that historically killed 50 to 100 million people at a time when the population of the world was 1/3 what it is right now. And the answer was very interesting because we found that virtually all other viruses that descended from the 1918 so-called bird flu were all versions of it. And right now, most of us are walking around with antibodies that are actually neutralizing what was a deadly, deadly virus a half a century ago. So that may not necessarily apply to one we haven't even recognized that will come up. But you know, if in fact there is one out there, I think all the kind of preparedness that we've all been talking about would have to be put to task to be able to respond. So I would envision that if it were a virus, that you would have either one of the platform technologies we were talking about, an mRNA technology, a DNA technology, a vectored virus technology, that we could see that virus, sequence it. You know, back then it would take months to see. We could do it overnight, sequence it, and essentially stick the appropriate gene into whatever vector, be it that a plasma for a DNA or a mRNA, and essentially start vaccines right away.
Thank you. My name's John Debs. I'm a continuing fellow at Stanford University in the Distinguished Careers Institute. My question is, in terms of vaccine for a flu pandemic or whatever, what areas are you considering? Have you considered gene therapy as a possible solution to this problem? Thank you.
I'm not so, you mean gene, I'm not sure what you mean by gene therapy. You mean a genetic, a molecular biological genetic approach to developing a vaccine? Okay, oh, I'm sorry, I didn't quite get what you, yes, the answer is, in fact, there is now a licensed product, that FluBlock, that is actually not growing the virus, inactivating it or attenuating it. And that's the goal of all of us, to ultimately, essentially, look for the gene that codes the protein that's immunodominant that you want the body to make an immune response against. And a typical example, and I really, it's a good, and if I might just tell the audience this, about the progression of how platform technology is important. With Zika, that back in the day, we would grow the Zika virus, we would inactivate it, we would either attenuate it, and then we would start to grow it up in mass amounts. What was happened is that as soon as we knew it was Zika, we found out that the immunodominant part of it, the part that you want to make an antibody against, is called PREM protein. So we just clipped the gene from the sequence that essentially was overnight, and we stuck it in a plasmid. For those who don't know, just a circular piece of DNA. We stuck it in there. But that plasmid we had a lot of experience with because we had already made a West Nile virus vaccine with that plasmid, which is also a flavivirus. So we had done months of work already. And what happened is that the Zika virus that's being tested right now in Puerto Rico, in Texas, and in South America from the time we sequenced the virus to the time we put it into a human in a phase 1 trial was 3.3 months, which is the fastest in the history of vaccinology. Not anything that we did so great. Anybody can do it now, so it isn't our talent, it's just the state of the field, how quickly you can do it.
Let's see, we've got a mic runner back here. Okay.
My name's George McFeeters. I'm a general surgeon from Honolulu and the chief medical officer of a small insurance company. Why have we not seen limited distribution of DDT, for example, to control, say, the outbreak of Zika in a limited area? That would be my first question. My second question is, I worked for 5 years as a general surgeon in Tuba City on the reservation. I wonder what evidence there is for the idea that there was discrimination against the Navajo during the outbreak. We were unaware of that on the reservation. It may have been talked about in Phoenix, but there was no discussion of that on the res.
Yeah, I could. So the issue, and I would be happy to share some of the stories. I mean, there was entire communities of school children from the Navajo reservation who were not allowed to go to Disneyland because they were coming from that area. There was a lot of stories in the local press about this, it's a Native American disease, as opposed to it's a newly emerging disease that happened to come from that part of the planet. So, it really was living there and seeing what's going on and being on the Navajo reservation. I'm not saying, that may not have been the perception that they were getting if you were on the reservation, but it was certainly what we were seeing happening to the communities that we were trying to reach out with, including, it was reminding me of the Ebola, the issue with the burial practices and some of the things that led to the continuation of that spread. We had the same issue when we were trying to solve what was hantavirus and why were 24-year-olds, 25-year-olds, 30-year-olds coming into the hospital with a flu-like illness and dying in 24 to 48 hours. So we need to do autopsies. Well, autopsies are not something that the Native Americans believe in. So we had to go through huge negotiations to say, okay, and finally we were able to just do quick, sort of core biopsies and sort of figure out how to work with the community in order to solve a medical mystery, but yet respect, their practices and so forth. So it was just a really interesting example of having to add all those other components onto something where we were just trying to save lives and figure out what's going on. And it slows things down and just adds a lot of nuances that are hard to probably describe unless you were part of that and experiencing it.
Mm-hmm. We had a bunch of questions sort of in this area here.
Hi there. My name is Andrea Yip, and I work at Johnson & Johnson Design in New York City. And thank you so much for this panel. I do a lot of user-centered design, and I think about the experience of people, and whether they're individuals or mass populations, it's making me think about the intersection between mental health and emergency preparedness and pandemics. And I'm just wondering if you can comment a little bit on that, if there's sort of a mindset around that, or what we need to keep in mind when it comes to mental health. Because I imagine with a pandemic, there's a lot of ambiguity, uncertainty, and even fear that gets stoked.
I mean, one thing that I worry about in the mental health, it's the mental health of the workers and the people who are left, after all of this emergency aid comes in, and, thinking about, post-traumatic stress disorder amongst, emergency health workers and communities. So I think that's an issue that we really haven't fully addressed, and, probably we'll see more and more of that manifest itself as we get, further out from the outbreak, but we haven't had a lot of experience with that.
This taps into what you were saying, Mark, as well, about the importance of the cultural factors, the importance of having the social science and the anthropology being integrated into the research we do on epidemic response, as well as the basic science, the translational science, etc. And I mean, it was really interesting, and even down to sort of how you communicate these things can have a massive impact. I mean, huge amount of evidence that during the early stages of Ebola, the message that went out in the 3 affected countries that this was incurable, that this was a death sentence, had a direct impact on the spread of the disease, because it led people not to seek treatment. It led people to not to isolate, to go and return to their families and very often infect them. And that's really critical, and we need to think very carefully about how, in these kind of situations, we're making sure that we understand all of the social factors that are leading to the spread. I mean, what was fundamentally different about Ebola was not, compared to previous outbreaks, wasn't really that the disease was any different. There wasn't some kind of dramatic mutation that had made this suddenly more threatening. It was where it occurred and what the cultural factors, whether it was the fact that these were essentially failed states with a huge history of civil war, or the local cultural factors that led to transmission, the population density, the fact that it was incredibly difficult to trace where people were going, all these sorts of things were really critical, and you've got to build that into the response.
If I could add, please. Yeah, so I think that it's a really good question, and the international institutions, I hope that we have learned a lot from Ebola. As Mark said, you know, it's important to understand the culture, the social factors when you go into a country to support. And I had the privilege of coming into Guinea at the end of the outbreak. So actually, when I came into Guinea, the outbreak was already declared over, and I was working with counterparts to strengthen the surveillance system and do some training with some local counterparts. But then we had a flare-up. We had some new cases of Ebola. So by that time, it was the end of the outbreak. It was last spring, and the international community as a whole had learned a lot. And so instead of going in, you know, like, we'll tell you what to do, we're going to do this, our intention was to collaborate with the community, was to pair every epidemiologist or every communication specialist with a local counterpart who explained to families like what we were doing when we were doing the contact tracing. And we were paired with families that they saw us every day, and so it built trust in those, you know, foreign people coming into their country and telling them about deadly diseases. And I had a lot of stories of just people being able to divulge information like, oh, my grandma looks really sick today, oh, you know, I'm not feeling very well, and not being resistant. And I think those type of practices, I hope we continue them. I hope they're integrated in training for responders going forward, because that can very much take care of this. I mean, not completely. I'm not a mental health specialist. I have a colleague who is, that's over here. But that could very much mitigate the harmful effects of, you know, just the impact and the brashness of response, how it can be sometimes. So, please.
So something that's related to mental health, but only indirectly. It's more perception, it's not really mental health like post-traumatic stress syndrome, is what the general public perceives as risk when you're thinking about an outbreak. So the people in West Africa were suffering terribly during the Ebola outbreak. We had 2 cases of Ebola of 2 nurses, one of which I had the privilege of taking care of, who got infected from the person who came from Liberia to Dallas. That person, 2 individuals got infected. 28,000 people in West Africa got infected, 11,000 died. The panic that generated in this country diverted our effort and our attention to worrying about where the real problem was. And I've seen this with the anthrax letters way back. You see it with other types of diseases, is that the American public, I guess understandably, has an issue with the concept of a new risk. And I refer to it as the relative risk phenomenon. So you live with risks that are real risks every single day. When a new risk comes in, that's far less risky than the risk that you're living with. You get panicked about the new risk. And that's exactly what happened. And I saw it, you know, we were one of the 3 designated centers to take care of Ebola patients. So myself and my team were taking care of patients. People didn't want to come near us because that there was a risk that they were going to get it talking to each other when everybody knew you had to essentially be knee-deep in body fluids. So I made the analogy, and I think they got it. I live in Washington, D.C., and we have a beltway that goes around the city. It's a very dangerous place to drive. So the chances of you getting into real trouble driving around the beltway to get to work to the NIH is about 1,000 times more risky than getting Ebola from a nurse who took care of an Ebola patient. Yet there was considerable amount of panic. So that's not mental health. That just is information that needs to put risk into its right category.
And if you think it was bad in Ebola, how's it going to be when it's flu?
Right.
Oh, exactly.
Well, but also, you know, with Zika, what I worry about is where was the mental health support for all the pregnant women in Brazil who, whether they got Zika or not, for that entire pregnancy, you know, without diagnostics, they were stressed. I mean, who's helping that whole cohort of pregnant women who, you know, we have no idea what that mental anguish is like during that process.
And led to unnecessary terminations of pregnancy.
Sure.
Hi, my name is Pia McDonald from RTI International. I'm an epidemiologist, and just following up on the comments about the mental health of Zika, we're actually working on a study with Brazilian collaborators looking at the mental health problems of raising children who are affected. So that's just a side note, though. I wanted to talk about something that I don't feel like we've touched on that much in terms of talking about the global health security agenda, and that is, we've talked about we have a lot of technologies and information and training products and all this kind of stuff to help mobilize communicable disease reporting. One thing we haven't talked about in the last day and a half is antimicrobial resistance and surveillance for that. If you look at the map that the WHO has produced about the large swaths of area around the world that we do not have data about antimicrobial resistance. And so we're lacking, you know, again, with the infrastructure in terms of people being able to do the diagnostics in these areas and then the lab samples going where they need to go and all that kind of stuff. But I just wanted to hear your view, you know, across the panel, because I know Wellcome Trust has been actually very engaged in this. Where do you see the next 10 years in terms of us as a global society wrangling with antimicrobial resistance? Because this is like some of these diseases we talked about, this is not going to like live in just one area, and this is going to cross socioeconomic boundaries, and there, you know, a political border is not going to matter. So I'm just curious about what do the next 10 years look like there, and you know, how can we as research organizations and companies and philanthropic organizations contribute to solving that problem? Thank you.
Who wants to start, please?
Well, maybe I can start, because indeed it's again a collaborative effort, because there was, for many years, there was not a real market incentive for new antibiotics. And there is a roadmap that CEOs of pharma companies have signed to work together with NGOs as well, a bit SEPI-like, I would say, to absolutely make sure that we create the right model so that there is, again, an incentive to work on it. And of course, it has a contradiction in terminus, which is antibiotics should be developed, not to be used, and only be used in case. And that's the controversy that you create when you want companies to compete for that. They should not. Actually, we should have the best antibiotics sitting on a shelf waiting until we need it.
Yeah, but there's a lot more to addressing antimicrobial resistance than just getting new antibiotics. I think what Luc mentioned was absolutely correct. But there are multiple steps that we need to implement, and if we don't, the problem is only going to get worse. I mean, the first thing is we have to have proper stewardship of the use of antibiotics, both by physicians who might inappropriately, usually from pressure from the patient, to give an antibiotic when you don't need it, to the use of antibiotics in agriculture for the growth of animals as opposed to the treatment of animals who might be sick. We need better surveillance, and one of the best ways to do that is to develop point-of-care diagnostics. One of the problems that we have, and I face it myself as an infectious disease physician, someone comes in with an infection, you're not quite sure what it is, or you know what it is, but you're not quite sure what the sensitivity is, so you start off with a broad-spectrum antibiotic, which is the first step towards inducing antimicrobial resistance. The other is hospital control. When you have an infection, and we had a real problem that got a lot of publicity at the NIH, we had carbapenem-resistant Enterobacteriaceae that resulted in a number of cases getting seriously ill and some dying. You got to be able to have good hospital control. And then after you do that, then you've got to do what we were just talking about how do you convince us to support the development of an antibiotic that you don't want to use very often. It's almost an oxymoron, telling a company to invest $1 billion in an antibiotic that few people will use. If they use it, they'll use it for 7 to 10 days. And ultimately, there's going to be resistance to it. So don't charge a lot for it, but do it.
And so what we need is to address that, we need to change the incentive structures around development. And certainly Wellcome is working on some of these things. We have an initiative called CARB-X, which is a very exciting kind of way of stimulating more early development of new antibiotics. And we're working too with others on what you might call the pull incentives, the incentives for people like Luke at the end of the day. There are a lot of different approaches to that. Wellcome was, as you say, was very involved. We commissioned, together with the UK government, Jim O'Neill, to do the big report into the economic consequences. But something else I want to say, also agreeing with everything that Dr. Fauci said, because those are the key things we need to do. There's also something important about how we communicate this issue as well. And so at Wellcome, we actually try not to use AMR, antimicrobial resistance, as a term anymore. We'll use it in the technical senses, but actually when we're talking to public, we don't use it. And that's off the back of some research we did that found that, well, first of all, nobody knows what it means. It's technical jargon. But secondly, worse than it just being technical jargon, it's actually counterproductive. When ordinary people hear antimicrobial resistance or even antibiotic resistance, which is perhaps more user-friendly, they often jump to the concept that it's their bodies becoming resistant to the antibiotic, not the bacteria that's becoming resistant. And we did some focus groups on this, and we found that a very simple change of language to make the noun in the sentence the germ, rather than the noun being the resistance, made a huge difference to people's understanding. So if you say drug-resistant infection, antibiotic-resistant bacteria, antibiotic-resistant germs, etc., you immediately make it much clearer where the locus of the resistance actually is. And that's really important, because if you believe that it's your body that's acquiring resistance, then one of your natural responses to that will be to stop taking the course early, which of course is exactly what you don't want people to do. So again, it comes back to this point that the communication is not trivial. It actually really matters.
Great. I think we only have time for one more question, unless we have covered. Well, I want to thank this fantastic panel and thank all of you for spending your afternoon with us. I hope it was helpful. Thank you.